Welcome to session 4 on this first day of Rhythm Interventions Online, and the pace does not slow at all. My name is Richard Schilling. I'm broadcasting from the Rio studio at Welbeck Heart Health in London, and we have another live case for you, this time from Devi Nair in Arkansas, who'll be doing a leadless pacing and AV node ablation for patients treated by an ablatant pace strategy. So carrying on with our combination therapy theme for today. Before we join Devi, let's meet our panel for the session. Helmut Purenfeller from Linz in Austria, Christian Veltman from Hanover in Germany, and Pugazendi Vijayaraman from Pennsylvania in the US. Welcome, gentlemen, and thank you so much for joining us. Remember, we're live, so I encourage you to keep submitting your questions, which we'll try and ask the panel and the operators. But without further delay, let's hand over to our live case operator, Devi Nair.
Hello, Richard. Can you hear me?
I can hear you very well, Devi.
All right. It's good to see you. Thank you for having us from Jonesboro, Arkansas. We are excited to be part of Rio 2021 this year. I want to start by introducing my team. I have Heath with me, who's scrubbing. Justin is going to be monitoring. Matt is with the Insight system, is going to help us with the ablation part. We have Mark, who is a circulating nurse in the room. I have Robert, who is with Medtronic and is going to help with the implant of the micro. And I have Roger, who is our CRNA. And Richard, we do all of our cases with CRNA because we have just excellent CRNA support, and we like the collaborative work that we do. So without further ado, I want to just introduce the patient. I have a 74-year-old pleasant gentleman that I met a few months ago for chronic atrial fibrillation. He actually came to me for consideration for a Watchman device as he was having frequent falls, and his Holter monitoring demonstrated significant episodes of tachybrady. He's been on anticoagulation, but having said that, his monitor showed significant episodes of bradycardia in the 30s, and which he was not as symptomatic with, but he had episodes of tachycardia in the 190s to 200s that would kind of make him near syncopal. So that was one of our reasonings to consider a pace and ablate strategy in this gentleman. He was not very excited about having transvenous leads. He's an avid hunter and wanted to kind of keep off of any devices in his chest. So we chose the Micro VR leadless pacing system. His ejection fraction has been normal over the years. His LV and RV function are normal. His right atrium, though, is a little bit enlarged, and is going to be a consideration as we put that leadless device today. So we'll see how that goes. Any other questions before I go ahead and start on the case?
So, Devi, do you have any concerns about combining the two procedures?
So it's a great question. I don't routinely combine the procedures, but I will say that I definitely do not combine procedures with the transvenous system, for sure. With the micro system, I have been, I actually have done a little bit more concomitant procedures because I feel like the system is a little more stable. Fingers crossed, the dislodgement rates are pretty low. Again, having said that, this patient requested to have one procedure rather than having to come back twice. it is hunting season in Arkansas, so we are trying to take care of the gentleman. So, yes, I have some concerns, but with the micro, not as much. So we're going to start with some lidocaine. Again, I do my access with ultrasound, especially for these large bore sheets. In any venous access, we have routinely done it with ultrasound. It's a very small needle, just kind of infiltrating that skin. Even though he's got a little bit of sedation on, we want to keep this part very comfortable. So we got lidocaine in. And I routinely get my access quite medially. Here's, you can see the vascular ultrasound here with the vein that's being compressed. And we'll go nice and medial away from that artery and come in a medial direction. And you can see my needle coming in the anterior portion. So we just entered. In that way, we avoid any kind of posterior sticks or any of that, any of those issues. Just for giving it a little time so I can show the prep of the device and the sheet, I'm going to introduce a short sheet in this case. I do make a generous skin nick to allow for the microsheet to get in. Shot back to you. This patient's anticoagulation was interrupted for 24 hours. That is our routine practice. Okay, so we're going to come down to the prep of the microsheet. You can see the sheet is being, we're prepping it on the table. It's a very hydrophilic sheet, so you just have to be very careful about handling the sheet. It's very slippery once you get it all wet. So here we have it on the table, all ready to go. I do use a Amplatzer stiff wire. You could actually use a regular long J wire as well, but there is some thought about the Amplatzer wire straightening out the venous system, but he's had some groin axis issues, so we're going to go with the Amplatzer stiff wire. All right. So we're going to put that wire up into the superior vena cava. Here we go. It's a flash of the wire in the SVC. So to dilate the tract, I'm going to use it's called a Kuhn's dilator, if you can kind of focus on this dilator in my hand. So this is a tapered dilator, so you don't have to use multiple dilators. It just tapers all the way from 20 French all the way down to 6. So that's a dilator that we're going to use in this situation. Richard, just as I start going into the sheet, once we put the sheet up, we are going to get the device prepped and move in pretty quickly. Because once the sheet is in, I don't routinely sit and wait around, because I do believe that the whole system can be pretty thrombogenic. Okay.
We're going to wait silent in admiration, Devi.
That's all right. You can keep talking. I don't mind talking. I think that once the micro sheath is in, we usually just kind of move. So I kind of do this clock and kind of counterclock motion to advance the sheath. The patient's extremely comfortable thanks to my excellent CRNA. I flash on that wire to make sure the wire is still in place. So this kind of helps move that sheath in very easily. And because it's tapered, that dilator moves in very well. So we're going to walk that back. Okay.
Yeah, so Devi, one of the questions I have, this is Pugal. So you said that you don't do AV node ablation and transvenous pacemakers simultaneously. I mean, the incidence of acute lead dislodgement is it's less than 1% in most cases. So why, I mean...
Mostly, I think, Pugal, it's the concern with, arm restrictions. And I just, even with the 2% risk, that has been a concern. I'll tell you, my practice of doing concomitant procedures is very low. I don't do as many. It's a very rare event that we do something like this, especially in a patient that specifically asks for this, even after we have not been able to convince them. And obviously, you know, from a hospital financial standpoint too, concomitant procedures are not really sought off as much around here. So we're moving in with the microsheath. You can see with the dilator going in, it's a small rocking back and forth movement. And we'll come up into the mid right atrium there. So this is a tall gentleman. You can see I'm almost to the hub, but I'll get up right up to the RA SVC junction with the tip of my dilator. And at this point, I just slide just the sheath up into the mid right atrium. And the reason why I bring that sheath to the mid right atrium is so that when I come in with the micro delivery system, I don't have to, I can just unsheath into the right atrium. So we'll leave that right there. At this point, we give heparin, and we're going to connect this, since we're doing an ablation as well, and we have the sheath in for a little while, we're going to connect it to a heparinized saline bag. Can I have a syringe?
How much heparin are you giving, Devi?
We're just giving 2,500, so we're not checking any ACTs or anything. We're just kind of keeping things less thrombogenic. Flush forward, please. Thank you. All right, keep it dripping.
This is Christian from Hanover.
So we'll leave that connected. Yes, Helma.
Yeah, sorry. Do you have experience with RV angiograms before you do the micro procedure? So we do it regularly, so we get an impression where the septum is, where the apex is, where the no-go zones are, where all the target zones are. And I think it's also very, very helpful if you teach new fellows in this procedure. Do you have any experience with that?
So I don't routinely do RV angiograms, but I always do an angiogram before I do my gooseneck maneuver. So I always confirm the position on the septum with the contrast shot before I implant the device. But I don't routinely do a full RV angiogram. In difficult anatomies, sometimes I'll use intracardiac echo if I need to. And obviously, if it's really difficult anatomy, we'll probably put a pigtail in and do an RV angiogram. But we don't routinely do it. So we're getting ready to prep the micro device. The micro device, if we can zoom in on the device, comes in, extruded out. So we are going to start with the flush. Can you hold that? So I have a 50 cc syringe here, and I'm going to flush the whole kind of channel out. And you can see we're going to fill that cup right here with saline, get all those bubbles out. And once that is all bubble free, and the cup is filled with saline, I'm going to bring that device kind of back in. And before I bring the device back in, I want to show this device here. If we can zoom in on the micro device. The device has these 4 tines that hold on to the RV trabeculae. So once we implant the device, that's what we're going to see pull back when we do the pull and hold test. So as we're flushing and the air is out of the cup, we're going to get the micro device back in the system. Okay, you can connect it to the manifold. We have a manifold set up for, we do our injections and stuff through our manifold. So we have a 3-way manifold set up. We've got saline and heparinized saline and contrast in one port. So with flush on both, heparin is in. As the flush is on, we have flush on here as well. We're introducing the microsystem. Yes?
Do you do continuous flushing also of the micro delivery catheter?
So I pause the flush as I put that in to avoid kind of a Venturi effect, and then I turn it back on once the delivery system is in.
No, I mean the
so the microsystem, yes.
Yes.
It is on
So I
continuous
think this-
flush. Yes, it is.
Yeah, this is very important to avoid clotting in the cup, right?
Exactly. Yeah, it is on continuous flush right now. Now we are going to introduce the microsystem until the delivery system transitions from the blue to the black. So you know that the system is within the sheet. You don't need to fluoro until then. We are going to fluoro once we get to that point. At this point, we're going to introduce the microsystem all the way to the tip to kind of line it up. Once it's lined up, I'm going to unsheath the system in the right atrium. I'm not pushing the microsystem into the right atrium ever. I'm always unsheathing it into the right atrium. So we're going to go into an RAO. So we're low in the right atrium there. Now rotate that towards that. We're going to slowly enter the right atrium. We have a large right atrium here. So the movement that I do is it's a slow up and down. So I'm not really pushing into the RV. It's a slow movement going into the RV. I have no forward push on it. So got pretty good clock on there. So at this point, before I make any additional movements, I will look on LAO. Let's look at LAO. We have a pretty steep LAO here, and you can see I'm looking towards the septum. We are going to do a contrast shot today, so we'll fill it up. And this is a very steep LAO, and we're looking very septally there. All right, ready? So we are in the mid kind of septum there. We could potentially go a little more septal if you need to. Yep. Come RAO and look at it again. So I have no forward force until I know that I am on the septum. Okay, let's go inject. So definitely not apical. We are in intrabacillary, so I am going to have some good forward motion in there. So at this point, I'm going to unlock my tethers, take the tether pin out, have the device ready to deploy, have a good clock on this. I'm going to have some good gooseneck on there. And I'm going to slowly release the device and take that forward gooseneck off. So we'll keep that tip in the right ventricle. We're going to mag up. Look at, I don't test my device until I do my pull and hold test, just in case if I don't see what I need to see, I can always move it before I spend a lot of time trying to find an angle where we can, let's get those cables off the patient if we can. Find an angle there we can see all the tines maybe. I think that's those EKG cables. Yeah, might just have to move something off if you can. Can you? Your hand's on there. Yep, that's a cable, but let you move your hand. Yeah, your hand off. Thank you. Yeah, that's better. Thank you, Roger. So we're going to mag up on there, and we're going to look and see. So we can see most of the tines there. I'll lock that off. Towel up there. Keep the flush on. So I usually will lock that off. I'll do it on a small sine run so I can go back and look at it. I can definitely see the top and the bottom tines kind of come apart so that I have at least 2 tines engaged. I can even see the back one kind of coming in, so at least 3 tines engaged. So at this point, we are going to test the lead parameters. Robert's getting the lead numbers ready. Any questions while we test those numbers?
Acceptable threshold.
So I start off with my R waves. if my R waves are small, I usually will go ahead and reposition right away before I even run all the other numbers. For threshold, if it's anything, it really depends on the patient. So ideally, I'd like to have a threshold under 1 before I leave the lab, but I'll also take into consideration the patient's comorbidities and risk factors that the patient has. If the patient has more than one risk factor, such as, say, diabetes or a female gender or low BMI, or they're on steroids or they have COPD, I'm okay with taking a threshold of 2 and then kind of sitting and waiting it out to see if it'll come down. And as long as it's coming down, I think there's enough data to show that over time it will come down. So I'm okay with that. So it really depends on the patient. Okay.
Debbie, this is Helmut. Is there any concern with extra beats, that you might have too many extra beats when you position and you think you should reposition that, or is this no concern because the tines will somehow find their ultimate site to engage?
Could you repeat that for me one more time? So you're asking me if I would reposition this?
Right. In case of a lot of extra beats, ventricular beats.
If there's a lot of ectopy, if there's a lot of ectopy, as long as it's not happening because of my micro delivery system, and if it's actually because of the micro, I would definitely move the for sure. What was the threshold? Okay. Well, what are you pacing it? Okay, we're running thresholds.
So Debbie, you talked about the threshold before you leave the lab, which implies you have some knowledge about the threshold changing even in the short time you're in the lab. Can you tell us a little bit about that?
Yes, I do think that the threshold, as long as there's data from Piccini's lab about if the thresholds are 2, as long as you give it enough time, those thresholds over time will come down to under 1 into an acceptable threshold as long as you wait. Again, it really depends on, in this patient, definitely this is a concomitant procedure, so we're not going to just take, mediocre numbers. We want to make sure that this is very good threshold and very stable device before I go and ablate the AV node, especially in this patient. And having said that, even though we came in to do a micro and an ablation, if for some reason I'm not comfortable with the numbers on the micro, even after repositioning, I will not ablate. I mean, there's always another day to ablate, and I think I can definitely convince a patient of that. But we definitely, look at what the numbers are before we get into the ablation mode.
Davey, so I have
so our threshold is 0.75 at 0.24.
So, Davey, you said that know that the threshold can improve even if it is 2. Are there any indicators similar to what you see with traditional leads, like myocardial injury current or something like that? What helps you decide that threshold is likely to improve? Because it's usually the contact issue.
Yep, agree. So the number one thing for me is I want to make sure that I had a good, I see those at least 2 times engaged. So if there's contact, the device was septal, there were good R waves and the impedance is good, I'm okay to wait. And as long as the threshold's coming down, I'm okay to wait. If all of the numbers have to kind of match up for me to take that whole waiting for the threshold to happen. If say if the R waves are bad or the impedance is bad, then I'm not going to sit around and wait. I'd rather move. Having said that, I also consider recapturing and repositioning the device. The more recaptures you do with the micro device, the higher the risk of myocardial perforation and injury. And you just have to be careful of that part. And that's something to keep in mind. And also keep in mind the risk factors of the patient that could predispose them to a higher risk for myocardial injury. And it's important in a micro case because if you have myocardial injury or perforation, it is most likely going to end up needing surgical repair. So I think all of that needs to be taken into consideration. So we have very good numbers. We have say that again, 0.74 at 0.24 milliseconds. So that's a very good number. We are going to go ahead and flush the system. So this is one time we're going to release the device. So I flush the system, make sure everything is good. And before as the flush is happening, I kind of floss these tethers here to make sure that it's all good. We want to make sure we stop the flush before we cut this tether. You don't want the tether to kind of get all bundled up with the flush going in. So we're going to cut off one end of it and slowly kind of go with the heart's beat, slowly release the device. So we're going to pull this out. All right, we're going to test this one more time because sometimes I've seen the R waves improve and the numbers actually even get better once you release because sometimes there's that pull from the tines. You can test again. Pull from the tines before, when it's still connected. So once you release it, it kind of settles in a little better. And we'll look at it again really quickly. Okay, we have the program ahead, so sorry. Yeah, so we definitely had an improvement in the R waves. So you'll notice that, I still have, yes, go ahead.
Just short interruption. Do you care about high-grade tricuspid regurg before implant?
Yes, I do. So this gentleman only had mild tricuspid regurg, even though his right atrium was very significantly enlarged. In cases of severe TR, I think it becomes challenging to sometimes get that micro delivery system into the right ventricle and keep it opposed onto the septum, especially because you can deflect it, but you can't maintain that deflection when you're implanting. You have to kind of release that deflection. So it can be challenging in those situations. So very important to kind of look at that 2D echocardiogram and have an idea of the right atrium and the tricuspid valve functionality before going in with the leadless case. Great question.
That's right, Debbie. Let me just ask the
okay, so we have stable thresholds.
So, Debbie, I'm going to ask the poll question. Sorry, the delay is making things difficult. But so one of the audience has asked, does the patient understand the risk of permanent RV apical pacing? Well, of course, the whole idea of the micro is that you plant it onto the septum. So often the QRSs are very narrow. But that leads on to the polling question, which is what has been your biggest limitation in implanting micro, which is what I want to ask the audience. Is it finding an appropriate patient, fear of complications, fear of RV pacing cardiomyopathy, concern of need for atrial pacing support, hospital approval or staff training, or reimbursement? So we'll come back to that a little later if the audience can answer that online. Debbie, you were just telling me that the thresholds in the RV look great now.
Yeah, the thresholds look great. I took the micro delivery system out because the cup has it can collect thrombus pretty quickly. So I went ahead and took the system out. I've released the system. We're gonna while we talk, we're gonna wait on a little bit. I'm gonna give it about a few minutes to make sure the numbers don't change. We've had stable numbers post deployment as well. Before we get into that, so the micro sheath does not have the greatest sleeve. You can't really put in an ablation catheter through the sleeve. It'll leak back. So what we're doing here to do this ablation is we're putting in a 16 French kind of short sheath that has a better seal in the back. And I'm just putting it into the kind of in the microsystem there. And that just kind of helps kind of prevent any backward leak. So that is kind of a sheath and sheath system here just to prevent any kind of back bleeding out of the microsheath as we go in with the ablation catheter. Now, because this patient, usually, I'm using a mapping system because I routinely use mapping systems for my ablations, but in this case, I'm going to use fluoroscopy as well because I just implanted a micro, so I don't want to go anywhere near it. Not that we worry about it, but because the right atrium was enlarged on the echo, I do have a steerable sheath as well that I'm going to put in.
So, David, do you really need to put a 16 front sheath if you're going to use an edgeless sheath, or will it still leak around it?
It will still leak around the agilis.
Okay.
You'll still need it needs at least a 16 or an 18. You could even get away with a 14, but you still need something that's a little bit bigger than that, or it will still leak. You can put a wire.
David, do you always use a long sheath to perform AV nodal ablation?
I don't, only if the right atrium is severely enlarged, or if I have concerns with leads or contact or anything like that. I usually start without a sheath and usually upgrade to getting a sheath. This case, because the gentleman has an enlarged right atrium, we chose to just go in with the sheath directly. So we're going to wire this back up. You can see you can take the program ahead out. We still have stable numbers. So we're going to go in with the wire. You can see the wire coming back up.
Can I ask you another question? So with the 26 front sheath, I saw that you didn't use any pre-closed systems. What kind of vascular closure systems do you use at the end of the procedure? Is it just the figure of 8, or you have the Vascade systems or AngioSeal?
So great question.
Pre-closed type of.
So we do use figure of 8 almost on 95% of patients, and I use a double figure of 8 with a stopcock to kind of a 3-way stopcock to kind of hold the pressure. In patients, especially last year and more recently, with patients wanting to go home the same day, or with the shortage of bed situation, or if there are patients that don't or can't lay flat for a certain number of time. Usually I'll have them down for at least 2 or 3 hours. If they can, then I'll use a pre-close. I'll do double pre-close with the per-close system. But it's not common that we do that because of the cost.
Okay. I have not seen a double figure of 8, so would they love to see it at the end of the case?
Yeah, okay. So we are going to go ahead and do a respiratory. Can you flip my screen, Justin, where I can see? So we're going in with the ablation catheter. This is
the panel. What percentage of your cases are now micro? We're certainly in London seeing a really steady increase as people really want these leadless devices.
You're asking the panel, Richard?
Yeah, so Helmut, maybe we could start with you.
We are not implanting the micro at the moment. So if we're doing a blatant pace, we have been doing all of these cases with CRT pacemakers, and nowadays we're already thinking about conduction system pacing, and we have implanted LBB pacemakers in those patients.
But in general, your number of pacemakers overall that are leadless now, is that something you do?
No, we don't do any leadless pacemakers at the moment in my institution.
Yeah. How about you, Christian? What percentage of pacemakers are leadless in your practice?
You can see our LS Pro system there.
So we are doing around 200 pacemakers a year and around 20 micros. So 10% of our pacemakers are leadless pacemakers, and we are limited by the reimbursement in our center. That's why we use it really in special cases where we have some points to make why we go for leadless pacemakers. So increased risk for infection, hemodialysis, immune suppressive treated patients, or after device infection, actually, we use these devices.
Sorry, Devi, back to you.
Okay. Okay, sorry. So you can see my ablation signal. We have a pretty good His signal there. I don't have a big atrial signal, but I don't see a whole lot as atrium is big. He is also extremely tall, so I'm running out of space. You can see my gillis is barely reaching up to the RA IVC junction. So this is the most I'm reaching in him. So we are going to go here, and we're going to ablate here. We have the pacemaker set at VVI 50, and we'll keep an eye. Usually if I don't get good junctionals within the first 10 seconds, we'll come off. Right, ablate, please.
So, Devi, even if you advance your outer sheath, you can get the edgeless into the atrium?
So we have junctionals as we are ablating. So the outer sheath, I could push it in further. I could get that outer sheath in a little bit more, but then that kind of affects the way the gillis is going to turn. I tried to move it up a little bit ahead, and I'll show you after I come off of this what was happening. It was pushing me back. So that's the reason I kind of pulled back. So move back there, come a little more septal, since I just had right bundle when I was ablating in that previous spot, so I moved back. So we have heart block here. I'll finish this lesion. Once I finish this lesion, I'll show you what happened when I tried to pull that sheath forward. Well, my goal was to try to move that back, move that sheath higher, but it just pushed me back further. Possible that the IVC is pretty tortuous too.
Yeah, Debbie, may I ask how are your energy settings for ablation? Do you use 50 watts, 40 watts?
So this one I'm doing 50 watts. If I'm having trouble, then I go to a lower wattage with a lower wattage. If I'm having to go into the Purkinje system, then I use a lower wattage and longer duration. But in this situation, since we got heart block pretty quickly, you can come off. We will just stick with 50 watts. And I did some along the right bundle, and then I moved back, and I did about 60 seconds, 30 seconds each in the more AV nodal area. So I'll show you. So we are at VVI 50 now. You can raise that number up to 70.
Or can you go to 30 to see whether we have escape rhythm?
Yep, absolutely, we can. In just a second. So I'm going to put this up in the SVC so I don't accidentally do anything. Can we go to VVI 30, please? So we have a junctional escape.
Nice, yes.
Yeah. So in this way, at least I have some peace of mind. All right, you can go back up. So we'll wait. We'll give it a little bit of wait time. So what was happening, Pugal, you were asking about the sheath. So I'm kind of hubbed out here. I'm going to move the gillis up here and move this microsheath up. I was having trouble at the eustachian ridge going up. So that's the reason I stopped right there. I did not. The tip of the microsheath can be pretty traumatic, especially if it's going over. There's so much tissue around it there's so much sheath. I guess it's a 23 French versus a 8.5 French gillis. So I don't want to just kind of slide over. If I had trouble, I would take the system out, put the wire back, put the microdilator back in, move the sheath up. I just don't like moving it up if I have any kind of resistance.
That makes sense. Because so if you had challenges with not able to have a stable position with the ablation catheter, then you would have moved the sheath up, get the edgeless closer into the atrium, then that would have helped with the stability.
That's right. I think it was mostly the eustachian. So I think the gillis kind of helped get me past that eustachian. So I had pretty good stability. And because I had pretty good stability, I didn't move it. But if I didn't, obviously I would get the dilator back in before just moving the whole system up. So we'll wait about 10 minutes to kind of make sure that this holds. And as long as this is good, we will get the sheets and everything out. We'll do sutures in the meantime. I was talking about the double figure of 8. This is one of the things that we have been doing over the last many years now. So the first figure of 8 is, if we can zoom in on the groin, if the axis side, thank you.
Can you also tell us
The
what
first,
needle
figure of
and
8.
what suture material is what you're using?
Yes, absolutely. So this is a zero silk. I have to ask what needle it is. I have no idea. They give it to me. How about that? So let's see.
CT1?
It's the truth. It's a CT1. Yes, it's a CT1 zero silk.
I'm just trying to figure out if I can learn new tricks from you here.
Oh my goodness. Okay. So here's the little figure of 8, or the Z, that goes in. So it's the first suture that comes out. It's right on top of the axis.
Okay.
And because it's ultrasound axis, sometimes if the tissue is, if the patient is very thin, then I'll actually do my figure of 8 with ultrasound as I'm getting access. So I'll actually put my wire in and do the figure of 8, just so I don't take an accidental bite from a blood vessel or something like that in a very thin patient. This patient has enough subcutaneous tissue for me to be able to do this after. So this is the first one.
Yeah, the second question I
Sure.
have you while you're doing that is that, so if you have a really obese patient, how deep do you have to have your figure of 8? Do you try to take a deeper bite, or is it necessary? Or that's always a challenge thinking.
Yeah, so the reason I went to a double figure of 8 is to avoid having to do really deep bites and a lot of tissue kind of crunched up together. So I don't do very deep bites. The CT1 needle only goes so far. I would say the depth of the CT1 is the most I would go. The second figure of 8 that goes kind of north of the first one kind of prevents the need for that deep figure of 8. So this is the first one. So we're going to kind of keep that right there. The second one kind of takes care of that tract that goes in. So it just goes just a little bit superior and north of the first figure of 8. And it's a little more deeper than the first one. And I do these for all my ablations and everything as well, because sometimes like the patient's waking up from general anesthesia, as they cough and stuff, that the figure of 8 sometimes can start bleeding, and with that second figure of 8, that kind of stops that tract bleeding quite a bit. What I used to tie long time ago, but go ahead. So
the second suture is above your puncture site, both the entry and exit points. Is that right?
That's right. So it's mainly just for the tract. And it's right above it. It holds that whole tissue and the tract as you go in, because my stick was not perpendicular. It was at a 45-degree angle. So the first suture is right at the entry point, and the second one kind of takes that, the tract where I did.
To compress that.
And I use exactly. And so then I use a 3-way stopcock to kind of hold compression. So we're putting the suture through it. This is a little bit easier than suturing it down or tying it down. This allows me to kind of release the pressure as needed. So what we do is we actually put the stopcocks in and use this as a manual compression device.
I see that you're using the thinner portion of the stopcock. Have you tried the other way around? Because I've been playing with both sides.
So
the sharper.
So I used the thinner portion in the past. So so my thicker portion is what holds my pressure. You can see the thicker portion is what's actually going to give pressure. For a really thin patient, you could use the thinner part. But that's, for some reason, that's more painful for the patient, at least from I've tried the other way. So now I actually use the more blunt section, especially for a bigger patient like this.
Okay.
Can we take VVI 30 again? So we're going to go back to VVI 30.
So maybe while we're doing that, Puga, can I ask you?
So I think we have
we've been asked
lost
a question by the
our,
audience.
from all the pacing. Yeah.
We've been asked by one of the audience, if you need to upgrade from VVI to CRTP, is that possible to do with a leadless device?
VVI to CRTP. I would think that every time I've upgraded, I've put in a full CRTP system.
I think there is a case report
Yeah, we
using the YCRT system. But you go from one expensive to another expensive system in the end.
And Helmut, you had something that you wanted to say.
Yeah. Would you do this approach that you do, Debbie, in a patient with a reduced ejection fraction? Because you told us that this patient had long-standing AF with a normal ventricular function. Would you do this kind of pacing, septal pacing with the micro, also in a patient with an ejection fraction of, let me say, 40 or 35? Would you do that?
I actually would not. I don't do a micro in anyone that has a ejection fraction less than 50. I tend to do it only in patients who've maintained normal ejection fraction over a period of years, not just the most recent one. So at least over the period of, over 4 to 5 years, as long as they've maintained normal ejection fraction, I do a micro. I will though say that there's some recent data from Ohio that showed that the need for upgrade with a micro compared to a transvenous device was less. And obviously the question is why, I don't know. But Dr. Hummel and all his data showed that the percentage of patients that were requiring an upgrade from a micro was less compared to a single chamber transvenous lead. So anyway, so having said that, we're actually ready to take the sheet out. We are gonna go ahead and give the pro to me. So what I did is I actually have a little bit of a hemostatic patch here. It's a CLOX patch. It's just a D-stat patch that kind of holds any kind of skin ooze, especially since we made a skin nick. So I have it actually engaged. If you can zoom into the groin, I have that patch engaged within my suture. So it just helps with the skin ooze. And I'm going to take the whole kind of system out here.
So which one, the lower suture is the one you're using first to lock?
Yes, I'm doing the lower suture first. I'm going to lock that down. And then I'm going to bring in and adjust the top suture. So I'm going to bring that down, push it down, and lock it in place. So the advantage, and then I'll come back and readjust the bottom one again, just to make sure that it's all well sealed and good. I think the advantage of the stopcock system is that in about 2 hours, I could release it, have the patient ambulate. If the patient is not bleeding, then we take the sutures out. Say if the patient ambulates and the patient bleeds, then I can always lay them flat and tighten it back in. Unlike if you tie it down, then it becomes harder for one to, hold pressure again. This is just a little bit more convenient. But otherwise, it looks good. Groin looks great.
And you're able to ambulate them after 2 hours?
So usually about in a micro, we actually will keep them down for at least 4. For the smaller sheets, we will get them up sooner.
And when do you discharge the
using
patient?
AV micros, Debbie?
Say again?
Are you using AV micros at the moment?
Yeah, we are. This patient obviously had permanent AF, so there was no reason to use an AV micro, but we are using it in patients with paroxysmal AV block and complete heart block as long as their ejection fraction is normal and they have good sinus node function and good right atrial function. So I do check the echo parameters before I put a micro AV, just to at least make sure that I have a good, I can at least hope for a good A4 signal before I put a micro AV device.
So do you look at an echocardiographic A waves or something like that, or what's your parameter?
Yeah. So so what I do is I actually do Dopplers, MO Dopplers through along the tricuspid and mitral annulus. We'll look at EA ratios. We are looking for a low EA ratio of less than 1.5, and I'll do TAPSE. So I'll look at the tricuspid annular planar excursion and look at the RA part of the TAPSE, and we'll look and make sure that it's a good number, that it's above 1.5. I think what I've seen is that if I have a good EA ratio and a good TAPSE RA, then I usually get pretty good synchrony, at least over 90% synchrony without any issues. It's the ones that have had, CABG or tricuspid surgery or things like that, where it's hard to assess those can become pretty challenging.
When do you discharge this patient?
So we have come out, taken the, so this gentleman is, he lives about good 70 miles away, so he's gonna spend the night with us and go home in the morning. We have routinely not discharged micro patients on the same day, unless they are from town and they have family in town. We are pretty, same day we're pretty high on same day discharge on everything else. I've just not surpassed that comfort zone with the large bore microsheath yet. I've really not had issues overnight, so it's just not come up, and patients have really not asked about it. So I don't know yet. Right now, they're still staying overnight, especially for micro.
Debbie.
Have you had to remove any chronically implanted micros, Debbie?
We have. The oldest one that I've taken out is 3 years old. But again, that was a gentleman that actually wanted it out. And, I don't routinely take it out unless somebody really asks for it. The really younger ones, the ones that we put in for, say, after extractions and things like that, we will take it out if the patient requests it. Otherwise, we'll just turn the micro off. As long as the patient is okay with it, we'll just turn it off so it just stays as a backup mode. We don't routinely, try to take it out, but I think that's going to be something that's going to come more and more, especially with the newer generation of the leadless devices coming out.
Debbie, one question to the AV node ablation part. I don't know what your experience is, but my experience in my lab is if you do it on a basis based on the new studies, Ablate and PACE studies, the APAV CRT, you see that there is even a mortality benefit if you do Ablate and PACE. And so the numbers have increased in my lab to do Ablate and PACE procedures. If you do this, then the ventricles get worse. You get ventricles with a high grade of dilatation, big ventricles, and a lot of remodeling. And what this means is that our rate of AV node ablation recurrences of AV conduction and also of left-sided approaches by the aorta to go there and to attain AV block has increased. This is your impression as well?
It's true. I would say that about 80% of the cases we are able to do the way we did, but 20% of the time we will take a retrograde aortic approach and get the AV node from the left side. And sometimes you have to actually come from kind of both sides and get it, especially in a pretty diseased heart. I definitely have to say that patients who have heart failure, who have a CRT device, who have permanent AF, my threshold to do an AV node is pretty low because of that mortality benefit. Patients just do much better not having to have so much AV nodal blockers on and having that appropriate BAVI pacing on a real-time basis rather than just always chasing it with that rate control strategy with just meds.
Well, we're we're almost out of time, so maybe I can ask the results of the poll and what did our audience think about their habits for implanting micros. Can we have the results of the poll? Okay, so interestingly, it's either dominated by the appropriate patient or reimbursement. And so I guess that, let me ask, Devi, you mentioned that you, one group, they've got to have an ejection fraction above 50%. What are the other criteria for implanting a micro in your practice?
I mean, I think for a micro VR, obviously it's a patient that has permanent AF and has bradycardia, or patients who have issues with any kind of venous access or previous lead issues, patients who want to avoid leads for whatever reasons. We have patients that ask for a leadless device because of cosmetic reasons. So those are usually the indications in my practice. I do use them as after extraction, sometimes more on more of a permanent device long-term in a post-extraction patient. Definitely for micro AV, that has expanded into patients who have good sinus node function and have AV block, intermittent AV block, very infrequent need for pacing. So these are my usual indications for a micro.
Wonderful. Well, so I think it's time to wrap up. I want to thank you and your team. It's nice to see some faces. I think I was last there 3 years ago, and I recognize some of the team there that's still there. I feel somewhat humiliated because it took me an hour to put in a micro last year, and you've done a micro and a AV node ablation, but I'll learn to live with that. And thank you so much for a wonderful case and so much to your brilliant team.
A great job, Davey.
Well, thank you, Richard. And I think I remember it being a 20-minute case.
Congratulations.
Yes, congratulations. Great,
Thank you.
Great job.
Great teamwork.
Thank you for having
there.
us.
Good job.
Thank you.